If you look at these pictures, you see the white, black, white, black. So that's just like your floor that you have. You have a concrete, you want to put a cement on the top, and then you have marble on the top. So the mucosa, submucosa, the white structures to make things easy for the people who not. So when surgeons are touching those patients, you say, can you give me the image? And then I will look at it, what it is. Because a PET CT might not be too relevant. By the time they come to you, they are coming for surgical ones. So you should not be attacking size of the lesion and also the dysplastic images, you need to look at it. So I just skip all these things just for the sake of these ones. So I'm just going to give you how we mark them for ESD to make sure that you have, because at least you need to be a couple of centimeters away from the margins to see the end block when you're doing the ESDs. So this is Barrett's esophagus to show what it causes. I'm just showing the EMR in this particular patient. So these dysplastic changes they're not dysplastic changes because I have done the full cleaning, because you never do the polypectomy in the same sitting that the patient comes in, because you need a clear clearing and you need to attack the high areas and then make sure when you take biopsies, they're always going to cause, if you leave it for more than a week, it causes fibrosis underneath it. That makes EMR extremely unresectable. People think they have removed the tumor, and then I see they use the APC to burn it, and recurrence is very high. So when next line goes on, you'll see why the EMR has got high recurrence rate is just because somebody has attacked it, taken biopsies. It all heals by fibrosis. What happens is T1A becomes T1B because it's plastered to the below flooring. When you break something, you try to repair it, it just makes it difficult. So, and then I'm just showing you here some images about the blood vessel that is there and how you did it, because
see that we made
I bought the conical one from UK to do that. When you're actually navigating through ESD, you need those ones to go so that you don't cause complications. You need so that when you got vessels, I also got this Pentax splash knife, yet not released in India, because it has got three-dimensional focus on it. So. And it just gives you how to select a patient. That's complete ESD is performed on this patient. So the question is, why EMRs have high recurrence? Why ESDs have more complications? When do you use EUS and all those things? I just made these ones, but just to make things easy, because there are a lot more information that was given by my colleagues, and I don't want to repeat them. So in a nutshell, here in India, T3 lesions, T4 lesions, very, very common, because they just afraid that will be diagnosed, because they know that they are having gutka, pan, cigarette smoking, and they have little dysphagia. They know that they have got this cancer that's going to come up. They want to delay it as much as possible, and then everybody attacks them. So early lesions, very hard to find. Nodular lesions within the Barrett's is very important, where you have to do a defined 20 minutes endoscopy for these patients, because you clean the surfaces, you use all your resources that is available, and then find out where dysplastic changes are there. If it is nodular, my algorithm would be just don't attack and take biopsies. You also use whatever, if you want, you use US to make sure T1A, T1B, and then take the biopsies from that. That's my algorithm, because if you biopsy there and they come back to me for my polypectomy scenarios, I just tend to see if it is biopsied more than a week, then a fibrosis is formed, EMR becomes very difficult. Then you have to move from EMR to ESD, because the lifting up as I told you, when you want to lift your tiles up, you want to make sure that there's enough surface beneath it. So that's what it is. So you need to find where who has done it, where it was done, how it was done, how large the lesion is, and what modalities do you have. Just not having all these tools, fancy gadgets is not what it is important. How we use it is what is important, because we have evolved from over a period of time in 20 years to allow only specific people to do specific functions, because those consultants don't do general gastroenterology. So we are all allocated to do polypectomies, we are allocated to Barrett surveillance, we are allocated to particular EUS. So our PAs are dependent on those things rather than doing a general gastro or IBD thing. So this is what we have learned over a period of time in UK, and that's going to evolve here as well. So just because we can do something, don't evolve into those things. Thank you very much.